My name is Sandro Galea. I have the privilege of serving as Dean of the WashU School of Public Health. Welcome to Public Health Ideas. These are conversations that mean to highlight work that's relevant to public health from faculty across WashU. Today, I have the privilege of speaking with Professor Ross Brownson. Professor Brownson is the Stephen and Susan Lipstein Distinguished Professor at WashU and Director of the Prevention Research Center. He also has appointments with the School of Medicine and Department of Surgery and the Siteman Cancer Center. Today, we're going to be discussing Ross's paper in the American Journal of Preventive Medicine called Understanding Misimplementation in U.S. State Health Departments and Agent-Based Models. Ross, welcome.
Thank you.
Tell us a little bit about what led to this work. Where did it come from?
Yeah, so I took a non-traditional pathway to academic public health. I spent the first 8 years of my career in a state health department, and I became interested in the idea of evidence-based public health, things that we are not doing that we should be doing. That sort of led into the field of implementation science. And most of that focus has been increasing the uptake of things that work to get people using it more. But then we started thinking about what about things that maybe don't work, that we shouldn't be doing, or things that work that we're not doing enough of. And that led us to this idea of misimplementation.
Can you define that for us?
I can, yeah. So I think we coined this term about 10 years ago, and there's sort of two sides to the coin. One side is what we call mistermination. And that means you've got an evidence-based practice, let's say a tobacco control program or a school-based physical activity program that is effective, that should continue, but is discontinued. So that's a mistermination. The other side of it is miscontinuation, when you've got something that's not effective. For example, a lot of local health departments still do a lot of health fairs. There's not a lot of evidence that those work. And so that's the idea of miscontinuation, that we're continuing it when it should stop. And so there's kind of two sides to the idea of misimplementation.
So how does that make the work of public health less effective?
Well, so if you kind of zoom out to the big picture, we spend something like $4.5 trillion a year on health costs in the United States. And about 40% of that is spent by the US government. If you look at the percentage of that that's spent on prevention and public health, it's a tiny fraction, maybe 2 to 4%. So public health is always under-resourced, and we need to do better with those resources. So if we're misimplementing something, if we're not making the very best use of those resources, we're not making a good investment in what we're doing, and we're not making the best efficient use of the precious resources. There's also a big need among policymakers to talk about return on investment. And if we're reducing misimplementation, we're increasing the return on investment. Success breeds success, and so if we have things that are working, we ought to keep doing them. If we've got things that don't work, we ought to stop doing them. So there's a kind of different layers of the reasoning for this.
Lead us through the paper. Tell us how you went about assessing misimplementation.
Yeah, it's sort of a complicated paper. We started with some descriptive data with the first surveys we did were about 10 years ago. We documented the sort of prevalence of misimplementation, how common it is. And then we began to look at some of the factors that lead toward misimplementation, either type of misimplementation. For this paper, we used a system science method called agent-based modeling. And that's a bottom-up approach where you identify drivers of complex health challenges. And in this way, sort of the agents can be individuals who work in a health department, or they can be the organization themselves, or they can be external to the health department, the policymakers who fund them. So there's different layers of this. And so agent-based modeling does a series of simulations where you try to get the best fit to the model for the different drivers of what might lead toward misimplementation, or in this case, trying to reduce misimplementation. And the agent-based modeling was the ideal approach to this because it's a complex problem. We don't know that much about it, so we don't have a ton of data on it, and it allows us to study complex organizations like a state health department.
So what did you find?
Well, we found that it's too common. We've studied this now in both state and local public health practice, mostly governmental public health practice. We find that the idea of mistermination, ending things that are effective, affect maybe a third of the public health programs out there. And we found the other version, the miscontinuation, is maybe a quarter of the health departments. We found that it's more common at the local level than at the state level, just like you might expect where the resources are less. And specifically from the agent-based modeling, we found that increasing a focus on evidence-based decision-making capacity, improving the organizational culture and climate of a health department, increasing a focus on innovation, and participatory decision-making in health department. How people share information, how they communicate within an agency, and then the biggest driver seemed to be leadership. And leadership matters, as you know, in every organization. And when leadership puts an emphasis on the effectiveness of an intervention, the effectiveness of an evidence-based practice, it seemed like that had the biggest impact on reducing misimplementation.
So what are we talking about in terms of if we can fix misimplementation? Fix is a very strong word, I realize. What benefits might we see? What's the scale of the benefits?
Well, if you could fix all of it, you could probably reduce waste in a public health agency by up to a third. So it could be a tremendous amount of resource savings, and those resources could be diverted to other uses within a public health setting. So let's say that there's a population that's not being reached effectively by a public health agency. The resources that are being wasted in a way on misimplementation could be diverted to a different population or different content area. And as you know, public health is always changing. And so that if there's a new public health issue that emerges, it also may give an agency a little more agile ability to adjust to a new public health challenge.
You talk about communication in your paper, and communication as a key to better implementation. What do you mean by this? What is more effective communication? Why does it matter here?
Yeah, that's a great question. I think there's several levels to it. One is better horizontal communication. In other words, if you've got program levels of people working in an agency, how they better communicate. Public health tends to get very siloed, where we have a tobacco program and an immunization program and a diabetes program, and often they're sort of insulated from each other. So one level is how people communicate better about evidence at that horizontal level. Another would be something from the communication world, audience segmentation, that we know that different audiences respond to information and communicate differently. So if you're communicating to a policymaker with no background in public health or science, how you communicate is very differently than how you communicate to another scientist. So we need to do a better job with that idea of audience segmentation, the messages we give out, and how we deliver that, which communication scientists call the channels. And then the third thing I think is, especially with policy audiences, and policy audiences can be an elected official, a state legislator, but can also be the head of an agency, which we would call a small policymaker, and a small p policymaker. And for that kind of a leader, we might think about data and stories, and weaving together data with a story, or weaving together a story with some data, so that we're always communicating in a way with the evidence, but we're turning into something that will resonate with the policy audiences as well.
How about leadership? You talked about leadership earlier. You said leadership matters, but what kind of leadership and organizational structure actually does matter and will matter in this context?
Yeah, so this is interesting. So in the early work we did, it looked like the flatter the organization, the less misimplementation. When we did the agent-based modeling, it didn't look like that hierarchical structure made as much difference. But what does look like it makes a difference is the idea of participatory decision-making. In other words, if there are big decisions that have big stakes, the strategic direction for an organization, for example, getting participation not only within an agency, but with all the different partners in public health can be very important. The idea of rewarding innovation. You know, we're not going to reward people in a governmental public health agency with a big financial package, but we can reward them with honoring their contributions. People get into, I like to say public health may be the one good infectious disease, because it gets in your blood and you want to keep doing it, and good practices can spread. So rewarding that good infectious disease, rewarding innovation, highlighting people that are taking practices and putting them to work and reducing misimplementation. And then knowing that every organization is different and it's never a one-size-fits-all, that we're going to have to do things differently for a large agency or a small agency, a rural health department or an urban health department, and then all the partner organizations. Most of this work is focused on governmental public health, but a lot of public health services, as you know, are delivered by partner organizations, private businesses, all different layers within a broader community.
So I really like this paper. I thought the application of agent-based modeling to it was a really innovative approach, so congratulations. What's next? Where do you take this work?
Yeah, it's a great question. We have a lot of ideas. There's a little bit of data we've collected from other countries. We've had one small study where we collected some of this data in the US, Australia, China, and Brazil, and there's huge variations. And so one would be looking at some of these issues in other parts of the world. Another would be this sort of state versus local. As I said before, it looks like this is more common at the local level, so understanding what might be different at the local level, understanding how partner organizations might play a really important role in reducing misimplementation and addressing this issue. And then one of the most challenging things in this work is the measurement of misimplementation. You know, in a medical setting, in a clinical setting, you have the patient record. You have something that you can go to that has some clinical record of change. In public health, we don't have anything really parallel to that. So we need to improve the measurement of misimplementation and make it more a part of the standard surveillance systems that are out there for public health.
In balance, are you hopeful that public health is heading to a better place in implementation? Less hopeful?
I am hopeful. I'm very hopeful in the long term. I think public health is never a straight line. It's always kind of this curvy road. But what I've seen over my career working, essentially my whole career with public health practice, is that people are much more aware of the evidence, the importance of evidence. We see a lot more leaders that are taking this seriously. And when we talk to people about the idea of misimplementation, they say, oh yeah, this is something we should be doing a better job with. And right now, I think one of the biggest issues we face is how do we take something that has been mostly studied by practice-oriented academic researchers and turn this into something that practitioners and policymakers can take home and do something about. But I am hopeful, and I think it's an exciting area for us, and I hope it's something that the new School of Public Health can have an impact on.
Ross, thank you for your work. Thank you for talking to us.
Thank you.
And thank you for being part of the conversation.